The definition of heuristics is mental shortcuts used to simplify problems and avoid cognitive overload. The heuristic is when you hear hoofbeats behind you, think of horses, not zebras. Comes later means that you should connect the throat symptoms with the right upper quadrant pain and come to a common diagnosis. But if we use the Hickham's dictum says that they have separate symptoms with separate locations and separate time of onset can be due to two different causes.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Welcoming all of you. The title of the topic is such that I have not expected many people to join. Heuristics is not a subject that many of us think will be useful, but at the same time, I think it's one of the most interesting areas of clinical medicine, and therefore, it is my pleasure to present it. Dr. Kumar has helped make this lecture. It's a difficult subject, but it is a beautiful subject, a beautiful area which is useful even in philosophy, psychology, mathematics, physics, etc., but especially in medicine. So let us start with the lecture, Heuristics in Medicine. The term heuristic is a very broad term, but it basically indicates a mental shortcut to arriving at a decision, whether it is in diagnostics, in deciding an investigation, or even deciding a treatment. We do this every day in and day out. Our mind is tuned to use heuristics. I'm just going to elaborate on them and maybe help us choose the better heuristic in a given situation. Okay, so here we go. The definition of heuristics is mental shortcuts used to simplify problems and avoid cognitive overload. Very simply, if a patient comes with metatarsalopharyngeal swelling and pain and redness, your mental shortcut is a diagnosis of gout. Doesn't take much to diagnose gout. There are no investigations that you have done. You have not aspirated the joint fluid, but you know the diagnosis simply by the symptomatology. So heuristics are helped basically by knowledge of symptoms, signs, and the investigations. So let us delve a little deeper into the world of heuristics. The one heuristic that most people know about is the heuristic, or that is called the zebra conundrum or zebra heuristic. As you know, the heuristic is when you hear hoofbeats behind you, think of horses, not zebras. The bottom line here is that always remember that common things are common. If an adult presents with a very bad sore throat, diphtheria would be a less common thing for you to think of than, say, a viral pharyngitis. So that is your heuristic. Let us go into specifics of heuristics. First, with a case study. This is a very recent case that I had in the first week of January. And this is a 29-year-old female living in Mumbai. She presented with fever, sore throat, odynophagia, body ache, and malaise, which started on the New Year's Day. And we did a telephonic consultation because she is a little far from where I am. And on the 2nd of Jan, that is 24 hours after her symptoms started, we heard this history. We did not do any investigations. We diagnosed acute viral pharyngitis as the probable diagnosis. Now, the heuristic that we used here to diagnose acute viral pharyngitis is the one that we spoke about, horses and zebras. We thought of the commonest thing first, and since common things are commoner than the others, we diagnosed acute viral pharyngitis. On 2nd of January, this was our diagnosis. And the diagnosis stems from the heuristic. When you hear hoofbeats, think of horses. So viral pharyngitis was our horse. Diphtheria, for example, would be a zebra in a 29-year-old. She had fever from the 1st of January, which lasted 4 days. Then she developed right upper quadrant pain with a worsening throat pain. This right upper quadrant pain was associated with severe nausea without any high colored urine. And this is when the second telephonic consultation happened. Now, think of this. She had fever 4 days, then she developed right upper quadrant pain. So one would think of viral hepatitis with prodromal fever. That is one possibility that one would think of. So here we started thinking of the differential. If we use Occam's razor, I'll come to Occam's razor, but basically Occam's razor means that you should connect the throat symptoms with the right upper quadrant pain and come to a common diagnosis which justifies both symptoms. And then we would suspect infectious mononucleosis. This is as per the Occam's razor. I'll be detailing Occam's razor for you soon. But if we use the Hickham's dictum says that they have separate symptoms with separate locations and separate time of onset can be due to two different causes. So if we believe in Hickham's dictum in this case, we would say, okay, this was viral pharyngitis and the right upper quadrant pain with the hepatitis-like features is nothing but a routine hepatitis A or E. So what happens? First of all, let us discuss what is Occam's razor and what is Hickham's dictum, and then we will remember to go back to this 29-year-old female who presented with fever, throat pain, followed by right upper quadrant pain with anorexia and nausea. What is Occam's razor? We will not go into the history of Mr. Occam, but Occam's razor says that you have to use parsimony in your diagnosis. Parsimony means का मतलब है कंजूसी. You have to be miserly. How do you become miserly? You try to explain each and every symptom by one etiology. So don't think of multiple etiologies for multiple symptoms. Now that is called Occam's razor. Does it work always? Of course not. It doesn't. But it's a good thinking process where you should try to correlate symptoms that are seemingly disparate. So the Occam's razor states that amongst competing hypotheses, the one with the fewest assumptions should be selected. So if the patient has throat pain and right upper quadrant pain, I can think of multiple assumptions. One is pharyngitis with amoebicular abscess. I can think of tonsillitis with viral hepatitis. But if it is possible to think of a combining diagnosis that combines the two symptoms, you should first think of that. That is called Occam's razor. So we in clinical medicine, we say try to explain all the presenting symptoms with one unifying diagnosis. That is your Occam's razor. Opposite of Occam's razor is Hickham's dictum. The dictum says a patient can have as many diseases simultaneously as they darn well please. Why can't they have more than one disease at the same time? Hickham's dictum, therefore, is opposite of Occam's razor. Now let us go back to our case. This patient had throat symptoms, pharyngitis. Then this patient had hepatitis symptoms with pain. As I said, if we use the Occam's razor, we say this is infectious mononucleosis and the upper quadrant pain is hepatitis of infectious mononucleosis. And if you say that both are different, then we can say this is viral pharyngitis and that is hepatitis A or hepatitis E. Remember, A and E are possibly a little commoner than infectious mononucleosis at 29 age, especially after 24, infectious mononucleosis becomes less common. Okay, now we go on to her reports. This 29-year-old lady finally was diagnosed as EBV, Epstein-Barr virus, hepatitis, sorry, infectious mononucleosis. So in this case, the Occam's razor came to be the correct method to follow. On the first day, did we order the EBV or did we just order when the right upper quadrant pain started? Did we order only hepatitis A and E or did we also order EBV? We ordered all three viruses because I had to respect the Occam's razor and think of Epstein Barr at the very outset. So we were happy to make a correct diagnosis based on Occam's razor here. Occam's razor works better when the patient presents with acute symptoms, when the patient is young, and when multiple complaints have started either simultaneously or very close to each other. If the symptoms have started at different times, it can still be one cause. For example, if a patient has gastroenteritis and after 15 days of gastroenteritis develops arthritis, then the both can be connected by calling this whole thing reactive arthritis due to a prior infection. We have used the Occam's razor to combine both the symptoms. In a young patient, this is usually more applicable. But if an elderly person comes with, say, acute gastroenteritis and after 15, 20 days develops swelling of, say, ankle and knee, this might be gout unrelated to the gastroenteritis. So in the elderly, Occam's razor may not work very well. In the young, Occam's razor works better. When multiple complaints start absolutely together, patient has high-grade fever with rigors, with severe swelling and pain in the joints of the hands and feet or other joints. In this patient, we have to say, okay, this arthritis and this fever are related, and if they have all started together, you can think of chikungunya as the probable diagnosis. So, if everything starts together, try to explain it by one cause. If it is a young patient, try to explain multiple symptoms with one cause. And if it is acute presentation, again, one cause may be easy to explain multiple symptoms. This is Occam's razor. When does the Hickham's dictum work better? I'll revise Hickham's dictum, which says that multiple symptoms can be due to multiple causes. So you can have a patient with abdominal pain, burning micturition, and knee joint pain. And the abdominal pain may be alcoholic gastritis, burning micturition can be cystitis, knee joint can be a separate osteoarthritis. Multiple symptoms can be explained by different causes, especially when the patient is elderly, especially when the patient is on polypharmacy, because remember, drugs can cause symptoms, and especially when the symptoms are disconnected in time. That is, they are temporally unconnected, they haven't started together. Then Hickham's dictum comes into play much more likely. Now, let us take examples. A young male presents with increased thirst, increased urinary frequency, and weight loss. What do you think of? Suppose the symptoms all started 2 months back and they all started close to each other. Greater thirst, greater frequency of micturition, and weight loss. You will all think of diabetes mellitus, right? Probably, all the three symptoms can be explained by one cause. If instead of that young male, an elderly male presents with increased thirst, increased frequency of micturition, and weight loss, these symptoms have been present since different duration. Patient says increased thirst is since 3 weeks after he started a particular medicine which has anticholinergic effect. His increased frequency of micturition is since 2 years, and his weight loss is since 1 month. The weight loss may be due to loss of teeth. The micturition may be due to prostate. So, if different timings are there of the symptoms in an elderly person, then you can explain three symptoms by three causes, three different causes, unrelated causes. So what is the key for us here? The key is that it is a no-brainer in history taking that each symptom must be inquired into thoroughly, especially with respect to the duration of the symptom. When I read histories of my residents, they will write cough since 3 days. Then they'll write fever. Then they'll write nasal discharge. Then they'll write body ache. Then they'll write vomiting. And after the first symptom's duration, the duration of the other symptoms are not written. And that's a huge mistake in history taking. Every symptom, of course, we should have origin, duration, progress, everything. But duration, every symptom must have a duration mentioned because that will determine whether you want to apply Hickham's dictum to explain the whole thing by its separate causes, or Occam's razor to explain everything by one cause. This is a no-brainer law. This is absolutely mandatory. If your history does not contain duration of each symptom, you are making a mistake and you will miss many a diagnosis. This we spoke of at least 3 heuristics so far. One heuristic was, of course, Occam's razor. The other was Hickham's dictum. We did talk about zebras, and we'll come to that again. Now we come to a person called Willie Sutton. Willie Sutton is an American person. He's dead and gone, but he was a robber. He used to rob banks, and he gave us the Sutton's law. He used to rob banks, get caught, go to jail, go free, rob another bank, get caught, go to jail, and so on and so forth. He would keep on robbing banks, keep on getting caught and put in jail. People asked him, why do you rob banks? Because they are high security areas. Somebody will catch you. There are cameras, there is security. He said, I rob banks because that is where the money is. You in medicine have to follow this man. Sutton's law says that go to the investigation which will yield you the diagnosis. Go where the money is. So this is our Sutton's law that guides investigations. This is also heuristic because it is a shortcut. You are not doing a plethora of tests to get a diagnosis. When deciding which test to do, choose the test that gives the best chance to reach the diagnosis. That is your Sutton's law applicable to clinical medicine. For example, a patient comes with myocardial infarction, ECG has some changes, and you want to do a blood test. If you are given a choice between CPK-MB and TROP-I, you have to go for TROP-I because it's the more specific test. CKMB is gradually losing confidence, and only in certain durations of pain will CPK-MB will be useful. TROP-I is the test to go for. So go for TROP-I. In pancreatitis, go for lipase. Cost is to be saved. Don't do amylase, just do lipase. You want to do enteric fever, Vidal is less expensive, but go for culture because that is where the money is. That is where the diagnosis is. In a lumbar canal stenosis where a patient has claudication, go for an MRI. Don't do an X-ray of the lumbar spine. It's useless. The yield is so poor. You have to get a high yield investigation. That is Sutton's law. Go for the kill. Similarly, in acute abdomen in the elderly, it's a very important area. Any elderly person presents with acute abdomen, except in the right upper quadrant, where sonography is useful, very useful. If a patient presents with acute abdomen anywhere else or a generalized abdominal pain, get a CT scan done without blinking your eyes, without blinking an eyelid. Get a CT scan done and not go for a sonography in an elderly person. The yield is much greater than a sonography. So these are examples of going for the kill in the patient's diagnosis, going where the money is. Okay, now another heuristic that we first spoke about, and that heuristic is very famous. When you hear hoof beats, तुम्हारे पीछे से ही आप खड़े हैं, पीछे से आवाज आ रही है तबड़िक 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 तबड़िक, तो you will think of horses, right? you will not think a zebra is coming from behind, because in India horses are much more commoner than zebras, as is in the most of the world. This is a heuristic to tell you that common things are common, simple. So if you have a patient with anterior neck pain, severe pain in the anterior neck, with tenderness to touch, your diagnosis because of this is thyroiditis. Don't think of malignancies or other esoteric diagnosis that will cause pain here. So, common things first. Now, acute epigastric pain in an elderly person who is a known case of atherosclerotic cardiovascular disease. Now, this acute epigastric pain, this patient may be on aspirin. This could be in a gastric ulcer. This patient is ASCVD. Myocardial infarction can present with an epigastric pain. This patient has ASCVD, can have an acute mesenteric infarction, or this patient, elderly patient, may have aortic dissection. Now, there are so many causes of acute epigastric pain in an elderly person. Your first thought should be to the commoner cause. Aortic dissection is the least common of these causes. But does that mean that you will ignore or not even think of aortic dissection? No. Zebras must be thought of. But to think of zebras, you should have the knowledge of the differential diagnosis. So, but always think of the commoner things first and start treating that instead of start investigating for that instead of straight away investigating for a mesenteric infarction or an aortic dissection. Now, a modification of this hoofbeats maxim or dictum is this. If you hear hoofbeats, think of horses before you think of zebras, but never forget the mules or the donkeys. Remember, mules are not as rare as zebras. Mules are not as common as horses. In some places, of course, mules are commoner. In villages, you will see more mules than horses. But in the city of Mumbai, for example, you will not see mules so often, but they are not rare. So, one of the key things that I teach my students in the clinic is in your differential diagnosis, if you don't remember the zebras or if you miss the zebras, it is not a crime, but it is a crime to miss the mules. Donkeys are obviously known to everybody. Anybody can, sorry, horses are known to everybody. Everybody can diagnose a horse, but a mule requires a good clinician. Let's take an example. A patient comes with acute epigastric pain after a binge of alcohol. What is the horse here? Meaning, what are the commoner things here? Severe gastritis or alcoholic pancreatitis. Acute abdominal pain after a binge of alcohol. What is the zebra here? Zebra is a holiday heart syndrome of atrial fibrillation due to a binge of alcohol with embolism occurring from atrial fibrillation into the mesenteric artery. Now, that is a zebra, right? I'm sure many of us can easily say that we have never seen such a case. Now, think of the mule. Alcoholic pancreatitis can be a direct insult by alcohol to the pancreas, but there is something called hypertriglyceridemia related pancreatitis, where the patient's alcohol binge suddenly raises the triglyceride levels and causes acute pancreatitis. Now, this is your mule. So, don't forget the mule, because this probably will change your management in some ways. Now, there are some heuristics that are unfortunate, some shortcuts that we take in our clinic, which are unfortunate and which make us make a wrong diagnosis. And this is very common, extremely common, and you will know why I'm saying that. There is a heuristic called availability heuristic. A patient comes to you with, in the season of mosquito-borne illnesses, a patient comes to you with fever and rigors. You have seen so many malarias or so many dengues in the recent few days that your first diagnosis is malaria. A simple extension of history taking would have told you that this patient has vomiting and flank pain or renal angle pain with high grade fever and rigors, and then you would not have missed the pyelonephritis. Or the patient has right hypochondriac pain with the pain that increases on moving or coughing, and you may not have missed the amoebic liver abscess. Availability heuristic means that you are influenced by the recent events. It is difficult for us not to be influenced by recent events. In COVID, every fever with cough and cold was COVID, right? But how many enteric fevers or how many infectious mononucleosis patients must have gone missed by our thinking only of COVID in that area? Agreed that out of 90, 100 cases, 95, 85 to 95 cases were COVID. But a good clinician is one who would not miss those 5 to 10 cases which were not COVID. So, availability heuristic is a trap that you should not fall into. The second is anchoring heuristic. Anchoring heuristic means a patient comes to you, comes in through the door, patient is breathless and patient is elderly, and you diagnose LVF in the first two sentences that the patient speaks. This is this LVF diagnosis does not change even after a complete history taking. I'll give the example of the history. 80-year-old female comes to into your clinic and says that I've been breathless since 2 days. Breathless is at rest. I'm extremely restless. I'm perspiring, and your diagnosis is made. You have said, okay, this looks like an acute coronary syndrome with probable LVF, and if you had only listened for a minute or two more to the patient, then your differential comes into play. But now your mind is fixed. You have said, okay, this all your questions are then related. Okay, did you get vomiting? Have you had chest pain in the past? Have you been breathless in the past? Do you have risk factors of heart attack, etc.? Now, if the patient tells you, okay, I also have some swelling in the legs because I came from London by flight uh, 10 days back, and around 8 days back, I got swellings in my legs and calves, and since 2 days, I am breathless. Now, your diagnosis becomes different. You are now thinking of pulmonary embolism. So, first thought that comes to mind has to be removed. You have to say, okay, the first thing that I think of, the first diagnosis that I think of is incorrect. Make that a resolution. My first diagnosis is incorrect. I'll come back to it if necessary. But I have to think of other things. This is wrong. I'm not. Patient comes to you with severe tremor in both the hands and is walking in a very tremulous fashion. Your first thought is now Parkinsonism, but banish that thought. Think of other things. Let the patient complete their history, their symptomatology, and then go back to your first diagnosis if you have. Anchoring heuristic is one of the most dangerous and unfortunate heuristics that you can have. And the third heuristic is confirmation bias, the tendency to diagnose in a way that supports your own prior beliefs. You believe that Vidal is a good test, and fever patient comes with fever of 5 days. You do a Vidal is positive. You have not bothered to see the patient's legs, and the patient has cellulitis in the legs. Because why did you not bother to see the patient legs? Because you know it is typhoid. You are sure this is typhoid, and even Vidal is positive. That is called confirmation bias. You have confirmed to yourself that Vidal is a good test. You have confirmed to yourself that this is enteric fever, and now nothing will change your mind. That is your confirmation bias. So we have to be away from these three biases. I think that ends my talk. Thank you very much. It's a complicated thought subject, and Dr. Kumar and I have worked on this subject since several years, trying to formulate examples and uh, but I think we can use these heuristics to improve our clinical diagnosis. Thank you.
Thank you, sir, for the talk. Doctors have been saying that this has been an extraordinary talk, and there's no doubt about that. So we don't have any questions, but we do have some comments that we'd like to share. Dr. Gupta presenting with severe pain in right shoulder joint, but no restriction in range of motion. Think of a maybe cleaver abscess in posterior superior quadrant. Any comments, sir, on that?
I think that's a good point. Right shoulder pain can be a radiating pain from areas that are supplied by the phrenic nerve, and one of the areas, of course, the diaphragm, and any diaphragmatic irritation, either from an umbilical abscess or a pleural effusion, uh, can cause this shoulder tip pain. And definitely, if there is no decrease in the range of motion, that is what you must think of, a radiating pain. Thank you, Dr. Gupta.
So Dr. Ravikiran asked heuristic versus algorithm approach.
As we said, heuristics are shortcuts. Algorithms sometimes can take the form of heuristics. For example, triaging for say acute coronary, sorry, triaging for acute coronary syndrome. We have algorithms, right? We have an acute coronary syndrome. We do an ECG and a tropi. ECG abnormal, go towards admitting the patient. ECG normal, tropi. Tropi abnormal, again patient admitted. Tropi normal with ECG normal, observe, maybe repeat ECG, repeat tropi. This is called triaging in an algorithmic manner. So this is your algorithmic approach. The algorithmic approach obviously is not a substitute for heuristic approach or a shorter cut, but it is based on shortcuts only, because you are now doing shortcuts in a organized fashion when you do algorithms. So in an acute coronary syndrome, your heuristic should be based on not just proper, because I think algorithms are governed by investigations more than clinical approach. Heuristics are governed by clinical approach, symptomatology, than by investigation. So my request to you is 70% of your uh, triaging or dividing the patient into this or that category, that's called triaging, should be based on symptomatology and the rest on signs and investigations. So we in the ER, for example, in the emergency room, as a patient is wheeled in, our first step is to look for TPR BP, meaning we check the pulse, we check the oxygen, we check the respiration, etc. And my belief is that after checking the patient, most of the emergency room doctors start investigating and don't talk to the patient or the relatives in detail. I think when the patient is stable, their airway is good, their circulation is good, breathing is good, we have to sit down, sit down next to the patient's couch and talk to the relatives and the patient as if we are doing it in the OPD. The outpatient history taking is far superior than the indoor history taking. We have to make it a habit to do the indoor history taking as well, because every time the indoor history taking is completed over days of the patient's admission, which is disaster. So, as Dr. Ravi has correctly said, that algorithm approach is a great approach, but algorithm approach is more useful, I think, related to acute patients, emergencies, but the principal triaging should be done by history taking. Thank you.
So next is another question from Dr. Gupta. Myriad of different symptoms associated with acute appendicitis.
Acute appendicitis is another good example of basically heuristics. As you know, acute appendicitis presents, especially in the younger person, with periumbilical or supraumbilical pain, and then gradually the pain over several hours localizes in the right hypochondrium, right lower quadrant, and then the pain is followed by, that typical triad pain, followed by vomiting, followed by fever. So now we have three symptoms, if you can call it four symptoms: epigastric or supraumbilical pain, right iliac fossa pain, vomiting, and fever. We have these symptoms separated by time, and yet they all four have to be combined together by using the Occam's razor to give you one diagnosis, and that is appendicitis. It's a very interesting area. In On the other hand, Hickham's dictum can come into play in acute abdomen of some patients. For example, if a patient, an elderly patient, presents with abdominal discomfort, vomiting, altered sensorium, then we know that any acute abdomen can cause altered sensorium. Any acute abdomen can present with more vomiting than pain in the elderly. But we also know that sometimes the drowsiness can be due to not the infection, but the hyponatremia in the elderly who has not eaten well. So we can have two differential diagnoses, infection and hyponatremia, separate in the elderly, in say appendicitis itself. So yeah, it is the process of triaging or a process of making shortcuts is very fascinating. Depends on the population. I think age is the biggest uh, criterion for choosing what shortcut is to be used, and of course the duration of each symptom is a crucial reason to uh, include it in the Hickham's dictum or the Occam's razor. I hope I'm not very confusing, but it is a good topic to discuss. It's a good topic to think. It's a thinker's uh, area where you can debate things, and so many examples of so many things, and this is day to day. It is on your clinic table tomorrow, whether or not you will be using the Hickham's dictum or the zebra principle, etc.
So the next question is any heuristic approach to syncope?
As I said, the most important part of heuristics is history taking, and if and syncope has also several algorithmic approaches in the symptomatology itself. So, if you have a patient who has syncope only in the standing position and never in the sitting or lying down position, that itself changes, makes your shortcut a little better. If the syncope is occurring only on walking and never in the stationary position, or if the syncope is occurring only after micturition or only after coughing, then you are different diagnosis. So syncope history takes you to a shortcut very fast. What is the commonest cause of say syncope in an elderly person? In an elderly person, the commonest cause of syncope is postural hypotension. Now it's so easy to fit multiple things into one diagnosis by asking the patient a proper history. You ask the patient, do you have to strain during micturition? Did you fall more than once after micturition? And your diagnosis, if the answer is yes to both the questions, your diagnosis that the patient has BPH, because of which the patient strains, and the syncope is due to micturition syncope due to vagal stimulation of the forceful micturition. Now, you have a diagnosis. If you ask the patient, do you have syncope only on walking? The patient says yes. Then very few differentials there. The patient has aortic stenosis as the cause of syncope. If the syncope occurs only can occur in the sitting, standing, or even in the lying down position. Sometimes the patient has unconsciousness. Then you know that arrhythmia can cause such syncopal episodes where position does not matter. So yes, uh, I don't know how to differentiate a good history taking method from a heuristic. A good history itself is a shortcut to your diagnosis. So I think every symptom has beautiful shortcuts to reach a diagnosis.
So next is from Dr. Jagrati. She says, any back pain with sciatica needs X-ray LS before MRI?
You will read in many in literature that lumbosacral X-ray is almost useless in radiating or discogenic pain. It does not show a slip disc. It may show some narrowing between, say, two vertebrae, L4, 5. but does not give any accurate diagnosis. So, in any patient with radiating pain, discogenic pain, or in any patient with bilateral lower limb pain of the claudication form, meaning pain on walking, which really is relieved by sitting down, that patient has to requires an MRI or a clinical diagnosis. If your clinical diagnosis is sciatica, that is sometimes good enough, and you can start treatment based on that and see what happens. But an X-ray will not take you anywhere. It is one of those. Sutton would never go to that area to steal money. An X-ray is not going to give him any value.
So Dr. Jyoti says, in current day scenario, how do you approach a patient with acute high-grade fever of 104 degrees with no other symptoms pointing to any infections, no body aches or generalized tiredness also?
Okay, so you are giving me an unusual scenario because 104 fever without any body ache, without any headache, without even malaise or tiredness would be unusual. But let me take that at face value that you have 104 fever and no localizing symptoms. So the most important thing, the most important algorithm in fever is checking out the localizing symptoms. Localizing symptoms are URTI symptoms are cough, cold. LRTI symptoms are cough, cold, pleuritic pain, hemoptysis. Urinary pyelonephritis symptoms are flank pain, increased frequency, maybe burning. Cystitis symptoms localizing are burning and frequency. Localizing symptoms of dengue are severe myalgia. Localizing symptoms of chikungunya are severe arthralgias and arthritis. Localizing symptoms of malaria are usually very severe headache. Localizing symptoms of enteric fever are few, but maybe some abdominal discomfort to begin with. I'm talking about onset symptoms. Localizing symptoms of ambicular abscess is right hypochondriac pain, of cellulitis is redness and swelling of the affected area. So there are localizing symptoms. And the first thing in any fever is to look for local. If there are no localizing symptoms and the fever is high grade to begin with, then my thought would first go towards malaria. Why would it go towards malaria? Malaria may be present without rigors, may be present without a headache. Dengue can get high grade fever at onset, but will almost always have very severe malaise and very severe uh, body ache. So, but of course, there are so many causes of high grade fever, non infectious causes, malignancies, tuberculosis can cause high. So, I would probably elaborate on that case and see what. But I'm sure there is more to this history. And Dr. Jyoti, of course, you will get more information from the case itself. Thank you.
So next is from Dr. Shinoy. He says, what is your opinion about syndrome approach in STDs?
Syndromal approach in STD. I must confess that sexually transmitted disease is not my area of uh, expertise or practice. But syndromal approach is used in almost all infections, right? So you have a upper respiratory syndromal approach, genital syndromal approach for STDs, etc. I have to learn from you more than you to learn from me. I think in this area, yeah. But I would love to hear from you if you want to come on stage.
Dr. Shinoy, if you could elaborate on your question. Till then, we'll move on to the next one. So Dr. Sonam asks, should we restrict this heuristic approach to emergency situation and that we should rely only on conventional history?
I suppose the question says that should the heuristic approach, because it's a shortcut and is a very quick approach, should we limit it to indoor patients in the emergency room, or should we use it in the OPD also? In your OPD, in routine cases, whether or not you have 10 people waiting outside, you are using shortcuts all the time, right? If you have a patient with fever and if the patient says the patient is also have burning micturition, your heuristic is made. You have already thought of Occam's razor and you are correlating fever with burning maturation. So heuristics are an automatic thinking process for all of us. So we don't have to deliberately choose a heuristic. Any clinician will be choosing a heuristic. Our main thing is how to avoid mistakes when we use our heuristic. For example, if we see burning maturation and we see a patient of fever, and if the patient thereafter says that fever is since 2 days, but burning maturation says in 3 months, and this is a postmenopausal lady, then you cannot have missed two different causes and used your Hickham's dictum, meaning burning maturation. Actually, not burning maturation is atrophic vaginitis, and fever is an unrelated etiology. So this is the key. You have your heuristic in place. Your bias already comes in when you hear two symptoms. But now is the test whether you want to use Hickham's dictum, whether you want to use Occam's razor, and arrive at the correct diagnosis. Yeah.
So Dr. Gupta says applying Saton's law by doing stop L test for multipathogen multiplex PCR in case of acute severe diarrhea with severe dehydration.
So what he's asking is now that we have a test called the multiplex PCR, and therefore that is where the money is. Sutton would go there to rob a bank because that will give you a diagnosis. Should we use the multiplex PCR in all cases of acute severe diarrhea? You know that there is a stool PCR test available, and therefore now I think we should not use investigations as a substitute to justify that we are following the Sutton's law and going where the money is. We must have a clinical. How many patients should undergo a stool PCR for acute diarrhea? Only those who are hospitalized. Now that is the rule in stool PCR. Only hospitalized patients should undergo a stool PCR test. Stool PCR is not a great test because it's so many false positives. You can get 4 organisms, 5 organisms, maybe 6 organisms in one stool PCR. Come to the multiplex PCR for monsoon fevers. Now, that multiplex PCR does have 5 monsoon fever tests: dengue, malaria, enteric fever, leptospirosis, and chikungunya. Now, if a patient comes to me in monsoon with high grade fever and I'm confused and I'll do a PCR, multiplex PCR, I can do that. But if the patient has chikungunya symptoms, fever with severe joint pains, cannot bend his fists, then I should do only a chikungunya PCR or nothing at all. Sometimes I can get away without doing any PCR. Need not confirm the diagnosis when the clinical diagnosis is so apparent. So there are tests which will 100% tell you that this, but more wise is to use your clinical sense. Don't waste the patient's money. The patient is not really a bank which you can raid like certain raided banks, and save their patient's money. Yeah.
So taking the last question from Dr. Kumar, complex regional pain syndrome, what should be the approach?
Wow. Again, this is a difficult area for me because I've not seen many cases. But complex renal pain syndrome, for example, the kind I have seen, which used to be called shoulder hand syndrome, are syndromes that occur in the upper limb, especially in this area, wrist and hand, or in the shoulder after an acute injury or acute myocardial infarction. Uh, you know that shoulder hand syndrome has pain, severe pain, and swelling sometimes, like arthritis. It's a complex syndrome. The treatment is, I don't think there is any definitive treatment, and therefore, usually symptomatic treatment. People have used NSAIDs and steroids, both, of course, and the physical approaches also. Uh, but it is a difficult diagnosis to make sometimes because it is a diagnosis sometimes of exclusion, where I don't think there is a specific test like there is for rheumatoid arthritis for a complex regional pain syndrome. Again, something that I'm not an expert at. A rheumatologist is the best person for this. But if you have any more information than I have, I would love to hear from you.
With that, thank you, sir, for taking in the questions from our doctors. And also would like to mention that there's a lot of appreciative comments for this session. Doctors really loved it. Thank you once again for this session. Thank you for doing this with us, and hopefully we'll see you again soon.
Thank you so much. Bye bye.